Hello, good evening, good afternoon, and good morning for those of you joining from around the world. Thanks for joining our Friday night happy hour here in the States. This is our 7th in the Plan Mecca Digital Mastery Series. My name is Jody Rodney, and I'm the Vice President of Marketing and Education for Plan Mecca USA. Tonight we have with us Dr. Peter Green from North Carolina. And his topic today is CBCT Interpretation Crash Course for new owners and users. Before we get started, I do have a few housekeeping items. One, we have muted all of our attendees and you will not be on camera. If you are experiencing any technical issues, please submit the issues in the chat function and we will take care of those as quickly as possible. If you have questions for Dr. Green, please submit them via the Q&A function and we'll answer at the end of the presentation. We anticipate that Dr. Green's portion will take approximately 60 minutes and then we'll open it up to questions. We are recording the webinar and it'll be available on the registration link where you originally registered. And at the end, there will be a post-webinar CE survey via the chat function. Again, if you want CE credits for this course, you will need to fill out the CE survey and it will be available in the chat function at the end of the survey or at the end of the presentation. Without further ado, I'd like to introduce Dr. Green.
Awesome. Thanks, Jody. And good evening and happy Friday to everyone. I'll admit this format is a little bit different than what I'm used to doing. I'm used to seeing people face to face when I talk, but it's awesome. Plan Mecca is organizing this for everyone, given the nature of what's happening with COVID-19. So for the next hour, so we'll talk about cone beam CT with an emphasis for newer owners. So either you just bought one or you're thinking about buying one. And if you're an experienced owner watching this, I hope you still can take home some pearls. And if you're watching and you're on the fence about buying a cone beam machine because you're afraid of missing something, my goal is to bring down that barrier so you're more comfortable with using the technology. But before we get started, just a little bit about me. So I went to, did my dental school training at the Medical University of South Carolina in Charleston, South Carolina, a beautiful town right by the water. And then after dental school, I did a 3-year residency at UNC Chapel Hill for oral and maxillofacial radiology. So I took a little bit of a trip up north. And so for those of you who are watching that are not too familiar with college sports, UNC is really ground zero for college basketball, in my opinion. This past season, maybe not so much, but basketball's huge at UNC. And if you did not know, Michael Jordan did play here in college, and he won the NCAA championship for UNC his freshman year, which is crazy to think about. So he was just 19 at the time. So UNC's big basketball program and going to a game there is kind of like going to almost like to an NBA arena. It's humongous. So after I finished residency, I did challenge the board exam for the American Board of Oral and Maxillofacial Radiology. So I'm a diplomate of that organization. And at the moment, I am a private practice oral maxillofacial radiologist, and I am still an adjunct faculty at UNC. So here's a picture of the dental school, and I just go in, you know, a few times a month to volunteer and to help the residents there. And this is my lovely wife of 11 years, and who's also a dentist, actually a pediatric dentist. So a big thank you to Plan Mecca for putting this event together. I've been reviewing cone beams from different manufacturers for several years, used a lot of different softwares. I do hold Plan Mecca's products, both the cone beam machines with their low-dose capabilities and image quality, as well as the Romexa software in very high regard, even before I started speaking for Plan Mecca. And they've really made a great commitment to create a new 2-day cone beam CT interpretation course held in Chicago. So I was happy to be part in developing that. And they've really doubled down on education, especially now with everything going on with COVID-19. So they're really making it accessible for education through these webinars for everyone. So a big thanks to Plan Mecca for hosting this. All right, so let's get started. What are we going to talk about? So as promised, this is what we'll cover. Some tips to keep in mind when interpreting CBCTs to hopefully make it easier to review. Go over an example of workflow for how to review your cone beams. So really for the new owners, helping you develop a workflow for how to systematically review your scans. And so we'll get into what I mean when I refer to systematic review of cases. And then at the end, we'll end with some common findings that I tend to see often when I go through scans. So let's get right into it. It's Friday night and learn about some cone beam. So why is this all important? You know, there are some suggestions put forward by the ADA. In 2012, they came out with an advisory statement about the use of cone beam. Fairly quick read, and we'll highlight some of the key points that they made at the beginning and the end of the presentation. First off, they do suggest that you get some amount of education or training on CBCTs. So that might be part of the reason why you're tuning in tonight. And, you know, I know some of you who may not own a Plan Mecca cone beam, you know, most manufacturers should hopefully provide some sort of education. And again, we just completely revamped the new cone beam course for Plan Mecca that's held in Chicago. And the entire scan does need to be looked at, not just the region of interest. But know this, all the dentist needs to do is to check if something's abnormal or if it doesn't look like it belongs. So no diagnosis, just recognition if something looks like it doesn't belong. So you're not necessarily responsible for knowing exactly what it is. You just need to make a quarterback and either leave it alone, biopsy, or send the scan to another dental colleague or radiologist for a second opinion. And above all else, you know, document. Write down what you see. And really that's the big question that I'm asked a lot is, you know, do we need to look at everything in the scan? And we'll go over some other common questions that I've received over the years as well. But again, this was put out by the ADA in 2012, and it's pretty quick read. Okay, so really looking at everything outside of the region of interest, outside of the teeth, that holds true in with any image in dentistry, like this pan, for example. We're used to seeing pans every day in our practices. It's something we're all familiar with, but there's a lot of anatomy here to see besides just the teeth. Only problem is it's all squished on top of each other. All the anatomy is superimposed. So we're left with a 2D representation of a 3D object. And so all of this anatomy, I would argue, is much easier to see on a cone beam CT scan. You'll notice that all of these structures are much more easier to evaluate in a cone beam as opposed to a panoramic. Because there's a lot of anatomy there, you know, outside the region of interest. And this is just to show, to highlight, you know, all the structures that we can see outside of the dentition. So we look at this every day, you know, outside the region of the teeth. But I would argue that all of these structures that you see labeled are much easier to evaluate in a cone beam scan than a panoramic. And this is how it looks in a cone beam scan all laid out. So this is the 3D module view, is what it's called in Romexis. But this is the 3D representation of the patient. So here are the different slices. In the upper left of your screen, we have the coronal slice, which is like you're looking at the patient from the front, almost like a panoramic. So the left side of the screen is actually the right side of the patient, and the right side of the screen is actually the left. So it's like they're looking at you, just like a pan. Below that, we've got the axial view. So this is like you're looking at someone, you're looking up at someone from below. And again, the left side of the screen is the right side of the patient, and the right side of the screen is the left. And then we've got the sagittal view, which is just from the side. And then in the bottom right corner, we have volume rendering, which is just a 3D model representation of the patient's skull. So this is really good for overall patient education, especially if you were to map out the nerve and then you know, show that patient where the implant would actually go. Okay, so let's get into the first part of this to discuss some basic principles to remember when we're looking at our cone beam scans. So number one, we're gonna talk about comparing what we see in a scan to a mental image of normal anatomy. And I'll get into that in a second. Number two, we're going to look for symmetry in our scans. And number three, we're going to use a systematic approach to check out the cone beam scan. So first off, mental image of normal anatomy. Whenever you go through a cone beam scan, you want to compare what you are seeing to what would be considered normal, a normal example of anatomy. So we have a spectrum, right? So here's what we would consider to be normal. And then if you know what normal anatomy looks like, you should be able to pick out pretty quickly what abnormal looks like. But the more of these scans that you look at, if you're scanning your patients, you'll notice that there's a middle ground. Sometimes we do come across anatomic variations that are not necessarily pathologic or abnormal. They're just considered to be a variation of normal. So here's an example of what I'm talking about. Here's a sagittal view, so from the side, of the IAN. or the mandibular canal, as some people call it. So here we see the mandibular canal here in a patient in the sagittal view from the side. So this is, I would say, it looks normal. You know, the contours of the canal look normal. It looks normal in its overall size and shape to me. And that would be an example of a normal mandibular canal. So here's another sagittal view of a cone beam scan for a variation of normal. We have the mandibular canal here, but we also have a second right here. So this mandibular canal is actually bifurcated. So is it pathologic? No. It's just a variation of normal that you might want to consider, you know, if you were to be placing implants in this area. So not pathologic, but just a variation of normal. So again, just comparing what we see in a cone beam scan with, you know, normal anatomy, what we think should be there. And then lastly, here's an example of an abnormal finding. So here we see the mandibular canal that is actually looks dilated, and it looks enlarged in this one particular area. So we see the normal contours of the canal here, and then it widens before tapering down again and having a more normal diameter. So this would be considered abnormal. So there is pathology within that location of the canal. Okay, so next up we're going to look at symmetry. And so we want to look at symmetry of the shape or any changes in the density of bone. So we want to compare a patient's right side with their left side. We already kind of do this when we look at panoramics. So here's that same example that I spoke of before. And we kind of assess for symmetry maybe without even realizing that we're doing it sometimes. We know what a periapical lesion looks like in a pan, but what about the rest of the anatomy outside the teeth? So if we were to draw an imaginary line down the middle of this pan, that would help us compare the sides of all the remaining structures outside the regions of the teeth. And we can easily pick up on differences. So just because it's out of the region of the teeth, and we see all of this other anatomy besides the teeth, you know, if we just check for symmetry, you know, do the condyles look the same on the patient's right as the left, for example, then we can quickly pick up on differences. And it's the same thing with cone beam. So if you go through your axial and your coronal slices, you can compare both right and left sides. And so this is a really, really efficient technique to go through your scans. It quickly lets you pick up any differences. And so you can tell if something looks asymmetric or off when you're reviewing the scan, and then you can go back and investigate. So again, comparing a patient's right and left sides, we can do that easily in the axial and the coronal view. For the sagittal view, though, you do not have the ability to compare right and left sides. So when I review cone beams, I actually look at the axial and coronal views first, because I know I can look for symmetry between the right and left sides. I actually save the sagittal view for last. So I go axial, coronal, and then sagittal. So here's an example of using symmetry. Okay, so here we have an axial slice of a cone beam scan, and so this these dotted lines show you the level that we're at for this particular slice. And so this is an axial view, and so let's kind of cycle down down the mandible through the slices and see what we can find. So as I'm going more inferiorly towards the bottom of the mandible, there's an asymmetry there, right there. So we can see this area here, this low density or radiolucent area, and we do not see it on this side. So there's no lingual cortical plate here. But actually the surrounding area does look, you know, pretty well defined, and it looks like it's has a nice rim of cortical bone on the inside. But again, no lingual cortical plate here, but we do see the lingual cortical plate on this side. So now let's look at that same lesion in a coronal slice. And so we'll move anterior to posterior. And as we cycle back through the slices, use our principle of symmetry, and bam, we can see that there's something on the patient's left side that is not on the right side. And so this is actually depression in the region of the submandibular gland. And so this is also known as a Staphny bone defect. And so most commonly found in this area, and it's thought to occur by pressure of that submandibular gland on the bone, and it actually forms a depression in the mandible. And so this would not necessarily need to be treated other than maybe radiographic follow-up at the patient's next recall appointment, you know, in 6 months, just to see if there are any changes. But again, you know, if we just had a 2D image of this lesion, we would see, oh no, there's a, you know, a radiolucency in the mandible. It does not look attached to the apices of these molars. You know, I'm limited by, you know, my ability to form a diagnosis just off of this image. So really having those other dimensions really help. So again, you can see the axial view and the coronal view here. So next we're going to talk about having a systematic approach. And so whenever you look at a cone beam scan, you want to have the same workflow or viewing sequence every time, kind of like I said, axial, coronal, and then sagittal for me. That way it becomes habit and you become much more efficient and quick and thorough at reading these. So I like to do the same thing every time. And so what goes into having a systematic approach? Of course, before looking at the scan, you do want to review patient information. So patient demographics, like age, gender, medical history, and your clinical findings during the examination. In this way, you can actually correlate any clinical findings or their health histories with what you see in the cone beam scan. So this does help a lot. So you always want to correlate clinical findings with what you see in the cone beam scan. So I like to look at all those things first, as you know, especially the medical history, and then you review the cone beam. And this is entirely up to you for how you'd like to review the scan. Again, however you tackle it, do the same thing every time, and then you'll become more efficient at reviewing these. So some people actually like to divide the scan or the screen into thirds, and so they'll look at this front area first, where the teeth would be, in the maxilla and then the mandible, and then on their next pass through, they might look at all the structures in this area, like the condyles, for example, we can see here. And then at the end, they might look at everything else behind the condyles. So some people like to divide the screen into thirds and do it that way. I like this approach, though. I like taking a wide angle lens view and then localizing it. And so what do I mean by that? So with a global view, I like to look at the entire scan for symmetry. So for what I think could be abnormal, and any changes in density, like a radiolucency or a radiopacity. I know as dentists, we want to look at the teeth first, but I look at everything else first before looking at the teeth. That way I know that I'm not missing anything and I've done my due diligence. But then when after I take a global view at all the structures, then I localize to the teeth. So then I take a local view at the teeth and evaluate the periodontal ligament spaces, the lamina dura around the roots of the teeth. So I like to take a wide view, a global view, and then at the end focus locally on each tooth. And personally, that works for me. And so this is my search pattern, and I've mentioned it before, and I'll say it again. So, I always personally like to look at the axial view first, the coronal, and then end with sagittal. And that's because I can evaluate symmetry first in the axial and coronal views, and you can't do that in the sagittal. So again, axial would be this slice here, and then coronal would be down here, and then at the end, I like to look at the sagittal view, and that's because you can't compare right and left sides in the sagittal slices. So where to start? This is my workflow that I'm about to go over. So this is how I always start reviewing every case that I read. So first things first, you want to orient the cone beam. And so what do I mean by that? If you were to take a 2D pan, a conventional pan, on a patient, and their head was turned, their chin was up, their chin was down. If there was some error, that pan had already been taken. There's no way to adjust that with a conventional 2D pan. The great thing about cone beam is if a patient has their head turned or if their chin up, you can actually account for that after the scan's been taken. And so here's an example again of an axial view scan. And so, this patient's head is turned to the side. And so you can just go in your CBCT software and reposition them so it looks like they are looking forward. And this is actually really easy to do in the Romexa software. You just right click and and you can actually rotate the patient forward. And other software should have this capability as well, but eventually you can turn the patient forward and evaluate for symmetry. Again, we see our imaginary line here, and we've just oriented that patient in the axial plane. And then likewise, I do that for the coronal. So here, this is an example of turning a patient to their side in the coronal view. And again, just uprighting them, and then you are able to compare right and left sides evenly. And so, why do I make a big deal about orientation as the first step in this workflow? What's the big deal? What happens if you don't do that? Well, the patient's asymmetric. So just looking at this example that I just showed, here we see an axial slice of this patient. If I were to go through this scan, and if this was my coronal slice, this is what it would look like. Okay, just because this patient is tilted their head, if we imagine this is my coronal slice, this is what it would look like in the coronal view. So we could see maxillary sinus on the patient's left. We cannot see it on the patient's right. We could see part of the coronoid process in the mandible here. We cannot see the same structure on this side. And the orbits look like they're different sizes. So here's the orbit looks large on this side, it looks smaller on this side. So you don't have that ability to assess right and left sides. And likewise, let's look at this coronal view. If we slice the patient at this level, let's look at what that would look like in the axial view. So here's the axial slice taken at this level. And again, we can see maxillary sinus here. It looks much smaller on that side. We don't have the ability to compare right and left sides at this point. And again, we can see, part of the ramus here. We cannot see it on this side. So orient your patients first, and then that will ensure your success later on for checking for symmetry really, really quickly. So do that in the axial and the coronal views. I always orient my scans first. And then what's next? Next, I make a panoramic from the CBCT scan. And most softwares, again, should have the ability to do this. So why am I taking a 3D image and making it into a pan? And the short answer is, I'm a radiologist, but I'm still a dentist too. So I like to make reconstructed pans just to get an overall view of the teeth and the bone around the roots. And this, again, gives me, an overall, view of the maxilla and mandible. So, I orient first, and then I like to make a panoramic from the cone beam. And then here's my viewing sequence for looking at the 3D data. So you've heard me mention before, axial, coronal, sagittal, and that's what I do. So looking first at the axial view, these are the structures I'm looking at when I'm going down in my axial slices. So I like to look at everything that's dark first. So the sinuses and the patient's airway. So here we see the maxillary sinuses here. And then this is part of the nasal airway here. So everything that's dark, everything that's radiolucent is air. And so I look at all those structures first. And then next, I look at everything that is in gray. So I look at the soft tissue. And, you know, we just kind of see you know, in this example, a sea of gray, but you can see calcifications in soft tissue in cone beam scans. And I'll go over some of those at the end. But again, I look at everything dark, so the airway and sinuses, then everything that's gray and the soft tissue, and then follow that up with just looking at the maxilla and mandible, you know, the maxillofacial structures, the bone, and the cervical spine. And I look at those same structures in the coronal view on my second pass through. Again, you know, this view, the coronal view, gives you a different perspective than the axial. So I like to look at, again, everything that is filled with air, you know, the airway and sinuses. Then I look at soft tissue, then at the maxillofacial region, you know, the bone, and then end with the spine. And I know I've kind of been hating on the sagittal view, but the sagittal view does have really critical role. And so I save it for last, and I use the sagittal view. Again, you can look at airway and sinuses. So, you know, for those of you that are interested in treating, you know, obstructive sleep apnea, cone beam is really helpful to evaluate the, you know, for possible obstructions in the airway. So the lingual tonsils, the adenoids, you know, this view is really, you know, critical for evaluating those structures. So again, airway and sinuses first. You can evaluate the spine in this view as well. But I find the sagittal view best to look at the joints, the temporomandibular joints, and the teeth. And so I'll start in the sagittal view. I usually start in the condyle on one side, and then as I move across in the sagittal view to the opposite condyle, I'm looking at the apices of all of the teeth. I find the sagittal view to be the best for looking at the apices of teeth, as well as the condyles. So what about common findings that we can see in cone beam? And this is kind of a similar topic in, you know, when we're talking about what we can see in cone beam versus a pan, you know, am I responsible for looking at all these additional structures? This is a really common question that I get, is who's responsible for reading the cone beam CT? And you know, the easiest answer is that someone's responsible. Someone is, and really in most states, it is the dentist who takes the scan that is, you know, responsible for getting the cone beam scan read. But again, I want to emphasize that it's just recognition of abnormal and document what you see in a written report. So don't, you know, I don't want the fear of missing something from you. You know, I don't want you to have that be a fear and not purchase a cone beam machine if you're on the fence about going 3D for your office. really it's just about recognizing, hey, that's not supposed to be there. It doesn't look quite right. Let's document and, send the patient off for further evaluation. You've done your due diligence as the quarterback, and you have handled that situation appropriately. So no need to diagnose exactly what it is, just recognize normal from abnormal. And then follow it up with a written report, because if you didn't write it down, it didn't happen. So common findings. Just to end, I'll go over few examples of common things we see in cone beam, and I've got a few examples of each that we'll go over. So I've got a few in the maxillary sinuses, some examples in the alveolar bone, and some in soft tissue as well, because cone beam is pretty sensitive for finding soft tissue calcifications. So if you take a panoramic image of a patient and then a pan, or then a cone beam scan, you'll find, oh, maybe there are some subtle soft tissue calcifications that I'm seeing in this cone beam scan that I'm actually, I can't see it in the 2D pan. So cone beam is very sensitive for finding soft tissue calcifications. So just as a baseline, as a primer for the maxillary sinuses, again, for those of you new to cone beam, radiolucent or dark would be air. And so here we see the maxillary sinuses. So we see the patient's right maxillary sinus, the patient's left maxillary sinus. It looks like we've got a premolar or a molar here. And then here is the nasal fossa, the nasal airway. And so if you look closely at this image, you'll see that there's a little bit of gray stuff on the floor of the sinus there. We can see it on this side as well. So, we want sinuses to be completely dark, completely radiolucent, but every so often you do see a thin layer of gray at the bottom of the sinuses. And that is, the same density as the soft tissue, right? And so this is, either mucosal thickening in the maxillary sinuses or a little bit of fluid. And so, if you have a little bit of that, that's still okay. 1 to 3 millimeters of mucosal thickening is still considered to be within a normal range. So again, sometimes you might see, going back to the maxillary sinuses, so looking at mucosal thickening, 1 to 3 millimeters is considered normal. So whenever I see mucosa that's...
I'm going to stop you real
yes.
quick. You are not sharing your slides. So,
oh, I'm not?
No.
Okay. Yeah, that's... How about now?
Yeah, we're good.
Okay.
Everybody's been very patient in saying that things are going well. So you've got about 470 people hanging tight with you.
Okay, awesome. Thank you. So again, looking at the sinuses, 1 to 3 millimeters of mucosal thickening is considered normal. But if I see something above that, this is the question I ask myself. I want to know, what is the etiology? Is it because of a tooth, in this case, maxillary molar or premolar, or is it not due to a tooth infection? So I have 2 examples here of cases looking at the upper right quadrant. So here we see a sagittal slice of a patient. And as we move from the outside in, what I'm looking for is breaks in the maxillary sinus floor. So if there's erosion of the sinus floor because of a periapical lesion. So you know, just looking at this slice in the sagittal view, I could see there's some gray stuff in the sinus here. There's mucosal thickening or there's fluid. So I want to then, you know, go through the slices and just check to see, is there a periapical lesion that's, you know, causing this inflammation in the sinus. And so in this example, the sinus floor did look, you know, smooth and continuous. I didn't see any sort of erosion through the sinus floor. And so this would be an example of a sinusitis. So this mucosal thickening was not due to an infected tooth. It could be due to the common cold or allergies. And so it should ideally resolve on its own or with conservative management like medication or antihistamines. So again, this is not due to a tooth. And so here's another example of looking at a sagittal view of the patient's right maxillary sinus. So we'll be going from out and working our way in towards the midline. And so just trace with your eyes the cortical bone and the sinus floor. And so right there, we could see what was causing this inflammation. So we see tooth number 3, it's been endo-treated. Here's the crown, here's the gutta percha and the roots. But let's trace the maxillary sinus floor. We see the sinus floor here, and then it is actually blown open here from this large periapical lesion, and it has actually caused an erosion and a break in the sinus floor. So here's the periapical lesion, and then all of this is inflammation in the sinus because of this tooth infection. And so if I were to write this in a report, I would call this odontogenic sinusitis. So sinus inflammation due to a tooth infection, and in this case, non-healed endo. And so I always make this designation if I see something like this, because if there was inflammation in the sinus, and as the dentist, I wanted to refer that patient maybe to an ENT to be evaluated, you know, the ENT would want to know, okay, you know, is this, you know, can I remove any sort of etiology here as the ENT? You know, can I help with this, you know, inflammation in the sinus? Or is it really a dental issue that needs to be, you know, addressed by the dentist? So I always like to make the designation of if the sinusitis is odontogenic or not. So coming to the alveolar bone, I ask myself the same question if I see anything that looks like it could be, you know, either a variation of normal or abnormal. So is the lesion that we see, is it odontogenic or not? So here I have 2 examples for you in the lower left. Again, sagittal slices, because I like to use the sagittal slices to look at teeth. So we're gonna work our way from the outside in. And so as we cycle through these slices, we can see at tooth number 18, there's something that looks a little different from the other teeth. So we see this area here near the apex of tooth number 18. And so this patient had no symptoms, no pain, no evidence of etiology. If I were to see something like this, you know, this high density area, I would want to evaluate the PDL spaces just to make sure they look normal. And the PDLs here do not look widened at all. This just looks like a radiopacity or high density area near the apex of that root. And so this is an example of what's called a dense bone island. And so a dense bone island is just a little area of really dense bone, like the name would suggest. And so it's like almost like cortical bone or compact bone has developed in the marrow spaces or the trabecular bone. And so this is pretty common finding that we see incidentally a lot of times in scans. And these usually stop increasing in size with age. So as a patient reaches skeletal maturity, these will usually stop growing. And this is not necessarily pathologic. It's just an area of dense bone. And here's our last example in the lower left, looking at the sagittal view, starting from outside and making our way in. And so as we are going through the slices, we could see, yes, there's a radiopacity here, but there's also, a very large cavitated lesion here, so we can clearly see that there's an etiology. And, tracing the PDL space in this area, if we pretend that this, large cavitation was not there, tracing the PDL in this area, we can see the PDL looks wider here than it does in the distal root. And so, this would be an example of sclerosing osteitis. And so some of us in school, we learned it as condensing osteitis would be another word for that. But this is just where the periapical inflammation is long-standing enough to actually start to form really, really sclerotic bone around the apices of the teeth. So when I see something like this, this sclerosing osteitis, that just tells me, hey, this apical inflammation has been there for quite some time. And then we'll end it with soft tissue calcifications. So whenever I see a soft tissue calcification, I always ask myself, okay, where am I in space? Where am I in the soft tissue? And so that really helps hone your diagnosis for what this could be. So this is an axial slice, okay? And we're at the level of occlusion. And so if we can pretend this slice is this line right here, we could see these multiple, round calcifications on either side of the airway at the level of occlusion. Bilateral, okay, and we're in soft tissue, and we're actually at the area of the palatine tonsils, right? So these are tonsilloliths, and these are the most common calcifications that I see in cone beam scans. And the main issue here might be halitosis. Patients are usually asymptomatic except for maybe bad breath. And so, these patients sometimes, might cough these up, but, it's not anything that would really need to be treated. But again, this is the most common calcification that we see. And so just take a mental note at the level that we're at. So we're at the level of occlusion. But if we go a little bit lower in our axial slice, okay, so now we're at the level of C4 of the cervical spine. So here's the cervical spine here. If we cycle through the slices here, we can actually see additional calcifications on either side of the airway. So these kind of have a round, semicircular shape to them, and they look like rings of calcification at this level. So we're much further down. We're at the level of C4 of the cervical spine, And these would be calcifications in the arteries. So calcified carotid atheromas. So patients with these are more predisposed to having an increased risk for coronary artery disease and stroke. When I find these, the patients are usually already being managed by their physician and taking antihypertensives. So this is just something you document and just let the patient know that you found it. If the patient's not being treated for cardiovascular disease or hypertension, what do you do next if you see this? Then that would just warrant the patient following up with their physician. Oftentimes when I see these, the patient's already being medically managed for hypertension or cardiovascular disease. So why did we see that calcification much lower than the tonsillolus? And that's because we were at C4 of the cervical spine, and at that level, the carotid arteries, and this is an axial view of the carotid arteries bifurcate at this level of the cervical spine. And so at this area where it bifurcates is where we see a lot of buildup of the calcification. So that's why we would typically see the calcification at that level much lower in the scan than we would tonsillolus. So to close, last question I'll leave you with is for the new cone beam owners is to scan or not to scan. When do you use cone beam and when do you not use it? The ADA, the same article that I mentioned earlier that was sent out by the ADA at the beginning of the presentation does answer that question. And really the best answer is when you as a clinician feel that 2D does not adequately answer the diagnostic question you're trying to answer for your patient. So ultimately, I think you'll find that cone beam really helps with your diagnosis and treatment planning and ultimately leads to better patient care. And thank you very much for bearing with us as we were trying to deal with me getting kicked out of that Zoom application. So sorry about that, but anyway, that's it. Thank you.
No worries. Thank you very much, Dr. Green. Just before we move into the Q&A function, we have posted the CE survey in the chat function. It's probably moving up very quickly because of all the comments and thank yous. So Sid, if you can just periodically keep reposting that so that it kind of stays in everybody's site, that would be fantastic. And just so you guys know, I know we had a lot of people asking about additional courses. I will say that Dr. Green is doing an additional course on Monday for responsible radiology that is being hosted through Viva Learning, and you can find the link to register for that at info.planmeccausa.com/webinar, and I'll have Sid post that link there as well if you're interested in more. And then we have not yet spoken to Dr. Green about this yet, but we're hoping to maybe do an extended course during this COVID situation where we know that people are unable to travel. But we do host a 2-day CBCT interpretation and application and hands-on course for implant planning in Chicago. So once we start to get back to normal and we see that people are starting to feel comfortable to travel again, we'll get that back on the calendar again. So with that said, we can go ahead and dig into the questions. Dr. Green, I don't know if you want to follow along in the QA section because there are some words that I don't want to butcher. But I'll go ahead and get started with some of the easier ones. And I think that you answered this one, but what are the guidelines regarding doing a CBCT on every new patient in the practice?
Okay, so I don't see the Q&A.
Okay, no worries. I'll do my best to get
Yeah, I think I've got it, actually.
Okay.
Let's see. Yeah, so I see the Q&A section. So with regards to scanning every new patient, that gets into a really good discussion about, standard of care. And so the question is, what are other people doing in your neck of the woods with regards to cone beam? So are you the only cone beam owner? Are other people in your area using it, and are they using it on every patient? So the best answer is, with regards to, scanning every patient. If you have a cone beam CT machine that has a low dose option and you're able to collimate that field of view to just the maxillary mandibular dentition, the dose should not be greater than a panoramic. And so, the dose detriment to the patient would be, negligible. So my answer to that is, if you use a small field of view option just to the maxillary mandibular dentition, low dose, then you should be fine.
All right, so the next question is, how long does it take you to review and report on a 15 by 15 full scan CBCT?
15 by 15. Much less time now than as a first year resident. So probably 15 by 15, doing everything I said as well as writing the reports. And I put images in my reports, probably 15 minutes, 15, 20 minutes for a 15 by 15.
Great. So a patient's head is commonly tilted downwards in most of the scans I have seen. Is there a landmark basis for reorienting the CBCT prior to looking for symmetry?
Right. So if a patient's chin is tilted down, I usually base that on the hard palate. So I would go into the sagittal view, and then I would reorient the patient that way. So just make sure the hard palate is parallel with the crosshairs that a lot of viewing softwares have. So they have crosshairs going up and down and to the sides. So I would actually reorient the patient with the hard palate for that one.
Great. And just because we do have a lot of questions coming in on the chat, if you can submit your questions via the Q&A, it will help us keep them all in one location and be able to dismiss them as they are answered. Thank you.
Yeah. So I just see a few in the Q&A box. So one was, how do you take care of odontogenic sinusitis, extraction only, or ENT help, or sinus cleanup? So that would be based on the restorability of the tooth. So, it would be your call, to do endo or extract and do implant. So that would be your call as the dentist. So if you treat the source, if you treat the etiology, then that inflammation should subside. And so that's why I gave the example of the ENT. So if you treat the etiology, that inflammation should go down. So they wouldn't necessarily have to go to an ENT because you've already dealt with the issue. What if odontogenic sinusitis is asymptomatic? Yeah, that's a really good question. So that kind of goes off of what the first question was about taking scans on new patients in your office. If you take a low dose scan collimated to the field of view, you'll pick up those asymptomatic abscesses that are causing the odontogenic sinusitis. So that's the beauty of cone beam. You can see things in 3D that you just can't see in PANS. So if the odontogenic sinusitis is asymptomatic, treat the tooth that needs to be treated, and then hopefully that'll resolve the issue. A dense bone island, is that the same as condensing osteitis? So the itis in condensing osteitis is just referring to an inflammatory component. So condensing osteitis is that second example I showed, where there was that large cavitated lesion. You could see the widened PDL and the lesion at the apex, and then you could see that sclerosis of the trabecular bone around the root. So a dense bone island is no etiology or inflammation. It's just the body decided to make cortical bone in that area. Sometimes dense bone islands actually attach to the buccal or the lingual cortical plates. And so we would call those enostoses. And it's almost like an exostosis, like you'd see on the buccal. But instead of growing out from the cortical plate, it's actually growing in from the endosteum inward into the marrow spaces. So that's just a difference in terminology. But again, condensing osteitis would infer that there's some sort of cavity or fracture that occurred, and it's creating that really dense sclerosis of bone. Someone asked, would you want to check the coronal view also to make sure that it is actually attached to the tooth? I'm not quite sure which example that was referring to, but whenever I see something, I want to look at it in all three views. So the person that asked that is spot on. I just showed the examples tonight in one slice because of time. But yes, again, if you do see sclerosis or an opacity, I'd want to check all three views for that. Someone said, can this technology help with endo and seeing canals? Yes, it definitely can. You can find canals really easily. The best way to find canals would be in the axial view, especially those MB2 canals in maxillary molars. So if you take a small field of view of a maxillary molar, you should be able to find those missed canals. And sometimes you can see really calcified sclerosed canals as well. So the technology really does help for that. Someone also asked, what about fractures in teeth that cannot be seen in a periapical x-ray? If the symptoms, if the patient has symptoms, and something doesn't add up, and the symptoms suggest there might be a fracture, but you don't see it in a periapical, that is definitely the time to take a cone beam scan. You should be able to find a fracture, in the cone beam scan that you can't see on the periapical. It's more sensitive to pick up fractures with cone beam as opposed to PAs. Someone also asked, UNC has done some good research on radiation exposure. What is your take on it as a risk for our patients? That's a really good question. And so one of the biggest minds in radiation dose as it relates to dental imaging was a faculty member at UNC. He's since retired, Dr. John Ludlow. And so, my take on risk for our patients is there is always risk for developing, cancer with radiation exposure. There's always a chance of that happening. That chance with dental imaging is very low because the dose is so low. But there's still always a chance for that happening. So that's why I would strive to always try to keep your dose at a minimum when possible. And I will actually be talking about that on Monday night. So, cone beam, the dose varies widely, but I think you'll find that there are, many options to suit your needs, whether it be low dose small field of view or high dose, to find really minute fractures. There's a large dose range. So for your diagnostic task, you should be able to adjust those factors accordingly. Someone asked, based on radiation exposure, isn't the cone beam less compared to a full mouth series, PAs, or bite wings? Safer and less exposure for patients with more information versus 2D than cone beam. Yes, you're exactly right. So based on radiation exposure, a lot of times cone beam is less than an FMX. So, and I'll talk about this again on Monday, but cone beam doses vary widely. There's a very large range, and it is because of several different factors. One of them being, the manufacturer or the company that makes the machine. And of course, Planmeca's really spearheaded the effort to keep doses low, but at the same time, allow for really diagnostic scans. So the person that asked that question is correct. There you can take a scan, a cone beam scan, at a lower dose than a few PAs or definitely an FMX. It just depends on the company, number one, and the settings that you use. So with Planmeca's low dose option, you can take a scan of a quadrant, a small field of view scan for like the dose of a PA. So it's pretty powerful technology. Someone asked, would you?
Dr.
Yes.
I just wanted to chime in because we've had a couple questions ask if we can get your personal, or not your personal necessarily, but your email address for people that want to get scans read. Are you willing to share that information? And if so, I can post.
Oh, yeah. So Peter_Green at unc.edu is the information there. And, hopefully I'll meet some of you in person, if you're going to go to the, Planmeca cone beam course, hopefully I'd like to meet some of you in person because, I'm used to meeting people face to face. So yeah, Peter_Green at unc.edu.
Perfect. And then one other thing before we dig back into the questions, some folks have been asking about Monday's course, and we just got word through one of the attendees that the class is full for Monday. So what we would like to do is to schedule a follow-up program with Dr. Green and maybe expand upon it and go a little bit deeper. We'll work with him to get dates, and we will certainly reach out to everybody who attended this webinar to give you guys first access to the next one that we do. So I apologize if I gave bad information earlier, but we thought for sure that they had plenty of seats. I think there were 2,500 openings for Monday's course. So obviously it's getting a lot of attention. So we will do our best to get something scheduled in short order. So sorry for interrupting, but I just wanted to.
No, that's fine.
Asking,
so someone asked, would you take a cone beam on new patients rather than a panoramic, since you can get a panoramic with the cone beam, and the cone beam gives you much more information? The answer to that question, personally for me, is yes. If you could take that cone beam scan at the same dose or lower than a pan, but you get more information, why wouldn't you? That's a really good question. The resolution with pans, with traditional 2D pans, is really good resolution. If you were to make a pan from a cone beam scan, you might notice it does not look as, quote unquote pretty as a conventional 2D, but you get much more, diagnostic information from taking, a scan and looking at the patient in all three views. So if you can take a scan at a lower dose than a pan, my vote would be to take a cone beam. Someone asked, what is the best way to draw or map the inferior alveolar canal? And so this all comes down to personal preference. I know some people that like to go in the axial view, and each slice, they like to find the canal and map it that way. For me, I think it's easier to go in the sagittal, and because sometimes you can actually line up the entire canal in that one sagittal slice, and then that makes clicking down the entire length of the canal much easier. So I would suggest, personally for me, is drawing or mapping that nerve in the sagittal view. What other resources could you suggest to learn more about reading cone beam CT? Definitely if you can't make it to Chicago for one of those courses, there are a few good textbooks out there. Probably the most basic is called White and Farrow, Principles and Interpretation. There's a good chapter about anatomy in there, and it kind of goes through each slice and each view and points out the different structures. So White and Farrow, I believe they're on their 8th edition right now, and that's really good to just start out. And then if you're looking for something a little bit more advanced, I would say there's a book by Dr. Lisa Koenig, Koenig, and the name of the book is Diagnostic Imaging, Oral and Maxillofacial. So that would be a really good resource if you were looking to get a little bit more advanced. Someone asked, what is the equivalent radiation dose for ultra low dose for a 17 by 20 scan? So if Plan MECA will be doing a specific one relating to ultra low dose, I can look at it then. I do not have the answer exactly for a 17 by 20 off the top of my head, but if you were to do ultra low dose for around that size, I would say probably 30 microsieverts or less would be my estimate for that based on the size that you're giving me. So I would say around 30 microsieverts for a large field of view like that. So less than 30. Do I have a report sample or outline? Yes, so I write my reports by the anatomic structure. So just like in that flow chart that I showed you earlier, I have a paragraph about the dentition. And then after the dentition, I'll comment on the airway. After the airway, I'll comment on the sinuses. And then the temporomandibular joints, the cervical spine, and then I end it with just other findings like soft tissue calcifications. So I just go in that order, similar to the workflow that I showed on the screen. Someone asked, what is your feeling on giving the patient an informed consent prior to taking a cone beam, where you qualify that, quote, as a dentist, we're not trained on evaluating areas outside the teeth, jaws, and surrounding bone. However, since cone beam can cover a larger area, we want to offer you the opportunity to have your scan read. That's a really good question. My take on that is, as long as it's being looked at, that is totally fine. So if you inform the patient, you know, this is the fee for having it read, you know, that would be sufficient. What can't happen though, and just want to make sure I'm answering your question correctly, what could not hold up in court, in my opinion, is having the patient sign a document saying, you know, I waive, you know, anyone from, you know, I don't want to pay the money to review the scanner, or I don't want anyone to read the scan. I don't hold the dentist liable. I mean, you know, ultimately someone needs to look at it, even if it's, you know, you, the dentist, that took it. You know, whether or not the patient wants to pay that money for a report, you know, I guess is another issue. But, you know, if the patient didn't want to pay, you know, I would say the dentist would still need to have, you know, need to look at the scan. Someone asked, how often do I see bifurcated IANs in your patients? I've seen bifurcated IANs in mental foramen probably just a handful of times, probably less than 5. And I've read a lot of cone beams. There was one time where I saw it trifurcated. I don't know if I'll ever see that again. That was definitely an anomaly. But more often I have seen bifurcated ones. Radiologists take more time and detail to go through a scan. How much time would you expect a dentist to spend on their first review of an image of both arches only while the patient's there? I think, and the question is 2 or 3 minutes fair? I think if you were to just make a couple passes through the different views with the patient sitting in the chair, you're not writing a report. You're just kind of commenting on what you see in terms of, you know, apical lesions or PDL widening. So I would say, you know, less than 5 minutes is fair, because you're not taking all of those additional steps to review, you know, and to write the report. So I think less than 5 minutes is fair. And then the same person asks, is it safe to assume that they should then go back and do a more detailed review after? I think that's fair. I think that would make sense, especially while you're constantly turning your chair and trying to address the patient, you know, talking them through what you're looking at. So yeah, I think that you know, you'd want to go back and do a more detailed review. Is it possible to define what you want to see in the CBCT? If it is, isn't it better to have a total view instead of a particular tooth? I would say, you know, especially if you were to take a low dose scan of a you know, new patient evaluation, you know, you would want to evaluate, you know, the entire, you know, maxilla and mandibular dentition. I guess if it's not a patient of record and you know, you can localize you know, an emergency to a very particular tooth, you could just take a small field of view. You know, and if you're looking for a root fracture, you know, you could take it in high definition if you know, in HD mode if you really needed to. But I think for the purposes of you know, overall diagnosis, I think you know, I agree that a larger field of view would be sufficient. Someone asked, are enostoses as common as exostoses? Yes, they are quite common. So the dense bone island I showed was, not attached to the lingual or the buccal, but anastosis, I do see those quite a bit, and we actually have a really good example that we show in our cone beam course. But again, it's quite common to see that thick cortical plate move inward towards the marrow space. And then that person asked if I could show the tonsil calcification again. And so here that is, here's the axial slice. And we're at the level of occlusion here. This is what those calcifications look like. So just very punctate, round calcifications on either side of the airway. And so they don't have that, circular shape like they're, in the lining of the vessel, like that calcified carotid atheroma did. So again, it's all about levels for the tonsillolus. My understanding is that for a dentist to be certified, they should participate in advanced courses through organizations like the AAOMR. Are there other recommendations you have for certification courses, or do courses like this hold similar weight? So the best answer I have for you is get all the education you can. It's all about how in depth the CE goes, and how in depth you want to get with it. That's the beauty of dental, is you can really find a niche and really strive to excel in one particular area. So I would recommend at least a full day course, a 1-day course, and there are many out there. The one that we've developed for Plan Mecca is 1 full day of radiology, and the second day is all implant workflows with CAD/CAM and how to manipulate the implant software. So I would say at least a day long course. But any way you can get more exposure to it, like through webinars like this, would be an excellent starting point. I am pedo-ortho, says someone. I treat children and adolescent patients primarily, which my wife's a pediatric dentist, so I understand you there. Can you comment on if there are adjustments to settings needed to capture diagnostic images in these younger patient groups? Yes, so I would base that off of making sure in your settings on your machine, both a conventional pan or a cone beam, just make sure when you're imaging a kiddo that you use the child setting for conventional pan. But for a cone beam scan, I would suggest using the low dose protocol. With finding root fractures, it's all about the diagnostic task. With finding root fractures, you would want to use a little bit higher dose if you found a root fracture. But for an orthodontist, you're just looking for where the root is in the alveolar housing. So you don't need the 0.75 micron or the 75 micron voxel size for that. So you should be able to get away with taking a low dose, low resolution scan, and the dose will end up being equivalent or less than a pan. So I would say either child settings on a 2D pan, or if you have a cone beam, I would say take a low dose scan. Someone said, can we submit? Yeah, someone asked about CDT codes to insurance company if the cone beam is not read by a radiologist, but rather interpreted by the dentist. So the interpretation acquisition code is not specific for I had a radiologist interpret it. You can apply that code for if you reviewed the cone beam and wrote a report yourself. So your hands are not tied with that code. It just means that it was read and evaluated by someone that could be you, and it was documented properly. So I would say you could still use that code. But if you do write the code for capture and interpretation, that it does include that report, and so it does not, that could be done by you. It doesn't have to go to a radiologist necessarily. Someone asked, what is the orientation to see vertical fractures? Yeah, so the axial view is the best I find to see horizontal fractures. For vertical fractures, that's a little tougher. I would look in all three views, but the sagittal view would be really helpful to find a vertical fracture. You can also really find the subtle hint of a fracture, a vertical fracture that's just beginning to cause a radiolucency or bone loss at the side of the root by looking at the sagittal view. So you start to see a little bit of widening of the PDL, and eventually, over time, you'll start to see a little bit of bone loss. So it takes around 10 days for inflammation, either radiolucency or sclerosis to be radiographically visible. So I would say start with sagittal for vertical root fractures. Someone asked, can cone beam be used for diagnosing caries? Incipient lesions, I would say the best way to view caries would still be bite wings, but cone beam, there have been a few studies out there that have shown that cone beam does show cavitated lesions better than some traditional bite wings. So for incipients, though, I would not use cone beam to view incipient lesions. Someone asked, who should make the radiology reading or interpretation, the dentist or the oral maxillofacial or medical radiologist? That's the beauty of dental. It's, you are the CEO, you are the practitioner, you call the shots. It's like it's your own hospital. So if you were to do the acquisition interpretation code, you could read it yourself. And if you find something that you're not sure exactly what it is, you could, send it to, your colleague down the street, an oral surgeon or an oral radiologist. So, by definition, you can do that as well. So it's not like medicine where, in the hospital, every scan taken has to have a medical radiology report. Dental's kind of like the Wild West. It's, you have the ability to call the shots in your office, and as long as the scan is being read, and documented, you can do that yourself. Someone asked, do you take bite wings as well as cone beam for caries diagnosis? Yes. So again, saying, incipient lesions in cone beam, I would not feel comfortable diagnosing incipients in cone beam. So I would say bite wings as well as a cone beam. So a lot of people take a pan in bite wings, back in the day, but nowadays a lot of people just take a cone beam in bite wings as well. Someone had said, I like to make personally, I like to make a pan from the scan, and you could correct a poorly positioned patient in the scan software. In the example that you showed, the pan looked distorted. Is this because the scan position was not corrected by the software prior to converting to the pan? Yes, that is why the scan looked like it was not oriented properly. The thing with pans too is you can actually draw the area of focus that you want for your panoramic. So if you were to take a conventional pan, you are locked into a specific area of focus. We call it a focal trough. With cone beam, you can actually draw that area of focus yourself in the software. And so you can account for that. How close to the mandibular canal are third molars that are impacted, not worth extracting? That's a really good question. I am not an oral surgeon, but I can tell you that if the apices or any part of that tooth are touching the canal, so touching the cortical plates of the mandibular canal, there have been studies that have shown around 20% chance of some sort of either temporary or permanent paresthesia, anesthesia, some sort of numbness in the area. It can be transient or it can last a while and be permanent. So there's around 20% chance of that happening if it's touching the canal. Someone said radiology seems to be more limited at the student level, or at least it was in the past. Many say they didn't get as much training as they would have expected at the higher ed level. Do you feel enough time is set aside at the university level for your specialty? Meaning, do dental students get enough education on scan reading, dose technology, or is there room for improvement? I would say there was a recent study looking at education in dental schools, and it was actually quite low for the undergrad dental students. Every year I feel like more institutions are picking up on this. Personally, as an undergrad dental student, I did not have a lot of exposure to 3D imaging. I knew it was an option out there for dentists to use, but it was more set aside for the residents, the post-grad perio, ortho, oral surgery. So I think there is room for improvements. And going back to the ADA recommendations, they recommend getting some sort of education. And so, that could be in dental school or post-grad training, that could count. But if you weren't given that in dental school or your residency, then, they do suggest going out there and getting some amount of CE. So I think that more could be done. I remember being amazed in residency at UNC, the amount of radiology that the dental students receive. They get a whole semester on cone beam and interpretation, of both 2D and 3D imaging. So, some schools do it more than others. Do you see advancements coming down the road with regards to AI in your specialty to make it easier for the dentist in the future? Yes, I do. And there might be some trepidation out there with dentists as it relates to, radiology and AI. I think it's just another tool in the tool belt, and I think it'll become a really powerful option to help everyone. I think it's only a matter of time, and it's coming. There will always need to be, a human signing off on, a particular impression or diagnosis. So there will always be the human component. But I do think AI will be an option for a really good, diagnostic tool in the future. So I'm all about not fighting that wave that's coming. I think it should be, embraced. But again, I think there will always be that human component. I feel like I already answered the question about cone beam versus intraoral bite wings. So I would take a bite wings, either extraoral or intraoral, for incipient lesions, as opposed to diagnosing those off of the cone beam. Yes, a general practitioner can write a report. Oh, thank you. So someone said Plan Mecca, the ultra low dose protocol for 20/17 is 16 microsieverts using 600 millimeter or micrometer voxel size. So yeah, so large voxel size, large field of view, 16 microsieverts, that is less than a pan. So that is ridiculous how low the dose is getting with some of these protocols. So it does depend, the dose does depend on the voxel size that you choose. So 600 voxel size, that would be more than sufficient for general dental diagnosis. You know, if you needed fine detail, you could go to a smaller voxel size. That would just require a little bit more dose. Oh, carotid calcification. Yes, I can show that. So here is, you know, we just moved that slice low, you know, from the level of occlusion to below the mandible. So here we are at the level of C4. And so here we can see the calcifications look, you know, they look circular, almost like they're lining the wall of the vessel. And here we can see it as well. So as we're going through the slices, here is the kind of the round calcification. You can see it, you know, kind of forming along the walls of that vessel. So the calcifications themselves look different than the tonsillis that we see at the level, you know, of the occlusion. If it is the dentist who will do the interpretation, will it stand in court for litigation cases? Yes. So likely a question that would come up is, you know, did you, you know, seek a second opinion from, you know, your colleague across the street on the particular diagnosis? You know, I think where litigation is going with regards to imaging and dentistry is more along the lines of, did you use cone beam or not, you know, for a particular case. So, you know, the classic example would be, you know, a mandibular implants that ended up going in the IAN. You know, the question would be, well, did you base that off of panoramic, or did you base it off of, you know, cone beam data, a 3D scan? So I think that is more around where litigation is going. I think it's more, you know, did you use 3D as opposed to 2D? And the same person asked, is it recommended to take a separate pan from a cone beam because the CBCT cannot make real panoramic reformats? Yeah, the resolution, you know, it might not look as pretty, you know, in the reconstructed pan, but I would still use that and go through the slices, because you can evaluate the periodontium better in a cone beam than a pan. So I would not, personally, I would not recommend taking a pan just to take a pan because it, you know, it might look a little better. I would say, you know, use the reformat, you know, of the pan in the cone beam just to get an overall view, but then go through all your slices to look at that information. Speaking of insurance, if the patient doesn't have coverage for cone beam or the insurance company doesn't recognize it for dental, is there anything that we could do to draw attention to the need for cone beam? Do you recommend billing dental so we could send a message? You know, since this is a must and can offer radiation levels that are less than pans or intraoral. Yeah, insurance is kind of getting outside of my area of expertise, but I do know that medical billing is, you know, a lot of dentists are really catching on to the idea of medical billing. I think dental, it's only a matter of time, especially since, you know, cone beam was first created for medicine in its infancy, and then only after that did dental adopt it. So I think it's only a matter of time before dentists really, or dental insurance really catches on.
Hey, and Dr. Green, I will make a comment that on next Thursday, we actually have a webinar on medical billing. So it might be appropriate for this audience to join as well. And again, it's on our main webinar registration page if folks are interested in attending that.
Great, yeah. Someone asked about PANS and the degree of magnification versus cone beam. So PANS actually, the magnification can vary very widely, especially you know, with patient positioning errors. If a patient were to be positioned perfectly, and I don't have the literature in front of me to give you an exact percentage, but any PAN, you know, if it's a perfectly positioned patient, will have at least like 20% magnification. You know, I would not diagnose or use a PAN for exact measurements. The beauty of cone beam is the measurements are anatomically accurate, 1-to-1. So the voxels are, you know, the cubes, the 3D pixels, the voxels that we use for, you know, discussing resolution with cone beam. They're actually the same size on all sides of the voxel. So voxel's like a 3D pixel, and all sides are equal. And so that means for you as a practitioner, if you are looking at a scan, no matter if it's the axial, sagittal, or coronal view, that measurement should be the same. The only error will be in the finger movements used to create that exact or that particular measurement. So it's 1-to-1 anatomically accurate. And yeah, so someone, a playmaker rep did say 3 microsieverts for ultra low dose 3A PA or 3D PA at low res. Yeah, so that is less than a regular PA for a small field of view scan. And actually before this, I was talking to my wife about dose. We don't normally talk shop, you know, for dental, but she's a pediatric dentist and was really interested. And I said, you know, you could take a quadrant scan or you know, a small field of view scan with ultra low dose at, you know, at really low dose, less than a PA, and she was just floored. So the technology is always improving as well. So that's the beauty of it. You buy the machine, and it's kind of like fine wine and cheese. It just gets better with age. You know, you've got the hardware, you've got the machine, but these software updates are always coming out, and your cone beam will just get better with age. And I think I answered all the questions.
Yep, I think it's we're about time to wrap it up here.
Okay.
Thank you all for sticking on with us. I think we maxed out around 480 people, and we have about 180 that hung on through the questions. So thank you so much for your time. As I mentioned, we are looking to add additional opportunities in the very near term with Dr. Green. But once travel restrictions are up and people are ready to get back out into the world, we will have monthly CBCT programs in Chicago. And obviously we would welcome all of you to join and participate with us. So thank you, Dr. Green. Everybody have a nice holiday weekend for those of you celebrating Easter and Passover. Thank you.
Right, thank you.
Thank you, take care.